I am Dr. Manasvi Gupta, consultant physician working in SR Haryana. So today we'll be discussing about emerging benefits from cardiovascular renal metabolic aspects of empagliflozin and linagliptin. Cardiovascular disease is a leading cause of morbidity and mortality in adults with diabetes, with its onset estimated to occur 12 to 15 years earlier in patients with diabetes. The excess risk of ASCVD in patients with diabetes has been estimated to be at least twice that of those without diabetes. In 2015, the era of evolving dimension of cardiovascular care in diabetes management began with EMPA-REG outcome study, which demonstrated significant benefits of empagliflozin for severe mortality by 38% CV events, as well as MACE in diabetes and CV risk. All types of CV death were reduced with empagliflozin. More prominent absolute benefits were observed for heart failure related deaths and sudden deaths. The post hoc analysis of EMPA-REG demonstrated consistent CV mortality benefit irrespective of prior CV events, heart failure burden, CKD, baseline HbA1c levels, control of multiple CV risk factors, or background use of metformin. Meta-analysis of 37 trials involving 29,859 patients compared canagliflozin, empagliflozin, and dapagliflozin with placebo and other glucose-lowering agents and demonstrated that empagliflozin was the only treatment lowering the risk of all-cause mortality, indicating a protective effect. Among participants with a baseline history of heart failure, empagliflozin was associated with a numerically lower rate of HHF and CV death, with no heterogeneity between participants with or without baseline heart failure. Among participants who had an initial heart failure, empagliflozin was associated with a near twofold reduction in the risk of a subsequent CV death or death by heart failure. SGLT2 inhibitors might prevent the development of heart failure in diabetic patients. However, it is possible that many patients in these trials had underdiagnosed heart failure and that SGLT2 inhibitors are effective in patients with less severe asymptomatic heart failure. Several mechanisms have been proposed for CV effects of SGLT2 inhibitors, including osmotic diuresis and natriuresis, leading to blood pressure lowering, decrease in arterial stiffness and vascular resistance, decrease in weight, and decrease in uric acid and oxidative stress. EMPA-REG outcome showing that an increase in hematocrit, presumably due to vascular decongestion, was by far the most significant contributor with almost 50% to the improvement in outcomes with empagliflozin. Also, sub-analysis suggested that empagliflozin can ameliorate manifestations of heart failure by reducing signs of congestion as well as a requirement of diuretic. These mechanisms indicate that decreased circulatory volume, especially reduction of LV filling pressure, is an important mechanism contributing to a favorable cardiovascular outcome. Positive top-line results of EMPEROR reduced has been recently published in patients with heart failure with reduced EF with or without diabetes. It has also been reported that SGLT2 inhibitors promote reverse cardiac remodeling, improve myocardial energetics and filling conditions, reduce LV wall stress and mass, and reduce blood pressure and arterial stiffness. The EMPA Heart CardioLink 6 study demonstrated that empagliflozin could produce early reverse cardiac remodeling in diabetes and stable coronary artery disease. Transthoracic echocardiogram performed before and 3 months after the initiation of empagliflozin, when retrospectively evaluated in EMPA-REG outcome trial, it showed a significant improvement of diastolic function and reduction of LV mass index in diabetes patient with ECVD. Blood pressure lowering effect of SGLT2 inhibitor caused no compensatory increase in heart rate in EMPA-REG outcome trial, indicating that there was no further sympathetic nervous system activation and SGLT2 inhibitor treatment. Empagliflozin caused significant natriuresis particularly when combined with loop diuretics, resulting in an improvement in blood volume. This favorable diuretic profile may offer significant advantage in the management of volume status in heart failure patients and may represent a mechanism contributing to the superior long-term heart failure outcomes observed with these agents. From pleiotropic benefits perspective, EMPA-REG outcome trial demonstrated reduction of both systolic and diastolic BP without increasing heart rate with empagliflozin. Significant reductions in office BP in patients with diabetes and hypertension is reported with empagliflozin. Recently, EMPEROR reduced and preserved trial empagliflozin outcome in patients with chronic heart failure with reduced and preserved EF, published with demonstration of reduction in risk of primary composite endpoint with empagliflozin. Empagliflozin demonstrated a clinically meaningful 21% RRR in the primary endpoint of CV death or heart failure on top of background therapy. For preserved trial, empagliflozin has become first and only therapy to improve cardiorenal outcomes for the full spectrum of heart failure patients, regardless of ejection fraction. In Carmelina and Carolina trials, linagliptin has also demonstrated CV and renal safety. That was the secondary endpoint of linagliptin versus placebo or active comparator when added to standard care in patients with diabetes who were at high risk of vascular complications. The combination offers a suitable component in strategy to achieve target HbA1c without hypoglycemia and weight gain in patients with high baseline HbA1c levels together with cardioprotective benefits in patients. Thank you.